Next up, we have Representative Albright with House File 2115. As he's making his way forward, Representative Albright moves that House File 2115 be re-referred to the Committee on Health and Human Service Finance. We have the bill in front of us. Representative Albright, to your bill.
Good morning, Mr. Chair and members. Members, we know the quality of care provided in Minnesota is generally very good. We pride ourselves on it, and generally our providers are efficient as well. But as with anything in life, improvements can be made. Thankfully, steps have already been taken to identify the areas for further quality improvements, and we have providers in our state that have successfully taken steps to make such improvements in patient outcomes. It is from these efforts that the House File 2115 is derived to systematically adopt such reforms across Medicaid. First, in 2015, the Minnesota Department of Health issued a report to help identify areas for improvement. Using the Minnesota All Payers Claim Database and 2012 data for 4.3 million insured Minnesotans, the analysis found that Minnesotans experienced an estimated 1.3 million potentially avoidable health care events, accounting for nearly $1.9 billion, or 4.8% of total health care spending in the state that year. While not all of these events are actually avoidable, the report identified areas where we can look to take steps to improve and coordinate patient care and save costs. Potentially avoidable admissions, readmission, and emergency department visits. Secondly, our own hospitals in Minnesota have taken steps to look at rates of potentially avoidable hospital readmissions. They won the 2014 National Quality Forum Patient Safety and Quality Award for their Reducing Avoidable Readmissions Effectively. Over a 2-year period, the participating 82 Minnesota hospitals prevented over 5,400 potentially avoidable readmissions, helping patients stay out of the hospitals and save millions of dollars. This bill draws from what we have learned from both the Minnesota DOH report and the RARE campaign to help us reward value over volume and quality over quantity for our Minnesota Medicaid beneficiaries and taxpayers. And importantly, the bill seeks to do this without telling providers how to improve patient care. We just focus on and reward better patient outcomes and let providers continue to do their great and innovative work to figure out how to achieve these important goals. Mr. Chair and members, with this I have a representative from 3M who is an expert on the particulars of the analysis and the metrics of this bill. And with that, I will turn over the testifier's table to him for further explanation of the bill itself. Mr. Chair, thank you.
All right, welcome to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair and members of the committee. My name is Chet Strorny. I am a consultant working with the 3M Health Information Systems State Initiatives Program and have many years of experience in government healthcare programs, including serving as CMS HICVA Regional Administrator for the Department of Health and Human Services in Chicago for many years. I work with state Medicaid agencies around the country who have adopted 3M tools and methodologies in their payment and performance management programs. I'm pleased to be here today to highlight examples of state Medicaid agencies who have moved from paying for volume to paying for value, improving outcomes, and reducing waste. You received a document which provides detailed information about key characteristics of successful state programs, how these programs work, including details of the steps a state takes when they adopt one of these programs. The key characteristics of successful outcomes measurement programs include: 1, focus on the most important and costly patient outcomes. These include potentially avoidable admissions, readmissions, ED visits, emergency room visits, and complications. And as Representative Albright noted, those were the key avoidable events that were studied through the Minnesota Department of Health. Identify and quantify potential healthcare waste. Effective outcome programs begin with a state's systematic identification of the hundreds of millions of dollars in waste in their Medicaid program, with a full-scale analysis of their claims database to identify potentially avoidable cases and the total potential excess expenditures associated with those cases. As Representative Albright noted, Minnesota has already taken a substantial step forward in analyzing and identifying waste throughout its healthcare systems. As he noted, the report that was done by the Minnesota Department of Health in 2015, it identified 1.3 million potentially preventable admissions, readmissions, and ED visits through the state's all-payer claims database, and accounting for approximately $1.9 billion in cost, which is 4.8% of the state's total healthcare spending. This important study can be updated to serve as a baseline for the outcomes-based, value-based payment models proposed in this bill. Outcomes programs are designed to support hospitals and health plans in two essential ways. These organizations receive fair, clinically credible, and transparent performance reports with actionable information. And two, it creates financial incentives that motivate hospitals and health plans to focus on avoidable events and to create interventions to reduce them. States that have successfully saved millions of dollars by eliminating waste and improving quality actively engage their Medicaid health plans and providers in the initiative. Key steps include: 1, target preventable events, track risk-adjusted provider performance compared to state norms, distribute reports to plans and providers with actionable information, and establish financial incentives with rewards and penalties to motivate plans and providers to reduce potentially avoidable events. Let me just cite a few examples I think there's several, 8 or 10 examples in the paper that we distributed. In Texas Medicaid passed a comprehensive Medicaid reform legislation in 2011 that mandated quality-based payment programs for hospitals and managed care plans designed to increase efficiency, improve outcomes, and reduce waste. These programs were fully implemented by 2014 and are now generating more than $90 million a year in direct sustainable savings by reducing avoidable admissions, readmissions, and ED visits in their managed care programs, and avoidable complications and readmissions in hospital services. The state of Maryland, starting in 2011, Maryland's All-Payer Health Services Cost Review Commission reduced preventable hospital-acquired complications by 20% statewide in the first 2 years of the program, generating $105 million in savings. By year 5, preventable complications have declined by 50%, generating over $180 million in savings. And the result is better patient outcomes. The results of these effective programs have been published in Health Affairs and the New England Journal of Medicine. And there are other examples that we list, and certainly I would just echo what Representative Albright said about the very innovative program here that the Minnesota Hospital Association implemented and for which they received the National Award for Patient Quality and Safety. We have estimates of savings based on what has happened with these other states. A conservative estimate of savings and outcomes, if a program like this is implemented in Minnesota, that the two programs for both managed care plans and hospitals could generate a combined $50 to $60 million savings annually by year 2 and $70 to $80 million annually by year 3. The cost of implementation would be $500,000 or less. Generally, states, when they implement programs like this, will hire a payment consultant to assist them in the process. Thank you very much.
Thank you, Mr. Strani, for your testimony this morning. Representative Dean.
Thank you, Mr. Chair. Mr. Strani, I just had a couple questions about your how you've implemented this in other places. Some of the things that we have tried to look at in the last couple of years have been about kind of easy things that hospitals can do to lower cost and to improve service. And just kind of like the bottom of the tree would be like never events, and then infection, so never events, wrong site surgery, foreign body, those kinds of things. Then the next level up would be hand washing, surgical equipment cleaning, those kinds of things, to doctors not wearing ties, to those kinds of things that are kind of easy on the bottom. And much of that is just repetition and rules that people, habits and rules that, you do that actually have big measurable results. And I can understand how when you try to get people to do good habits, it's really hard, but then once you do it, you can see some effects from that. So that I really understand how to change the culture in order to do that, to pull down infection and readmission. Some of that is easy, some of it's harder. Then the next level up would be measuring outcomes and procedures, and that's when it gets a little bit thornier for comparing hospitals to each other with different patient populations, and I would imagine that you get some pushback on that. And then the hardest part is when you attach payment models of rewards and punishments for those outcomes. You talk about just if there's a kind of a scale like that of how difficult things are to implement and what kinds of pushback that you might get from people trying to implement such a thing. Obviously, these are all great ideas, but as you move up that ladder, things get a little bit harder. So what have been some of the difficulties and the biggest challenges in other states in implementing such a plan?
Mr. Stroney.
Sure. It's some very good question and a very good overview of programs and what is being done here in Minnesota. The healthcare system is very complex in this country, and obviously when a state approaches a program like this, it's very, very, very important that there be transparency and education with the involved providers or health plans. Very open communication. That's why the process will take anywhere from 9 months to a year to implement something like this. Maryland, in the Maryland example where they implemented potentially preventable complications, had extensive meetings with their hospital community. Yes, there is resistance to change, and we see that. However, the value or the effectiveness of the programs that we have seen implemented is that if using the claims data from the providers, in other words, the providers do not have to submit additional information, or the encounter data from health plans. That data is risk adjusted. So you mentioned the different population among hospitals. Some hospitals have sicker patients. So the hospitals are compared on an apple-to-apples basis because the data is risk adjusted. And the information is shared with those hospitals. Ohio, who is implementing a program like this right now, of potentially preventable readmissions, sent reports, I think it was for 2 years, to their plans and hospitals before they implemented any payment adjustment, any financial incentives. So there was a period of time for providers to adjust to this, to look at the data, look at their own data, look at their own systems, and how they can improve. The goal here is for providers to improve. We see that in the states that we've been working with across the country. I hope that answers your question.
Chair Dean.
Yeah, Mr. Chair, and it does, it kind of gets at some of the initial, obviously, resistance that you get at. And we were recently down at Mayo and just talked to them about how difficult it was to establish never events in their surgery department, and just about how basic that was, how they can get to 0 events in 10,000 surgeries by doing very repetitive procedures that were hard to implement. So it's really hard, it was hard for them to do, and never across 10 is easier than never across 10,000.
Right.
And they're able to do that by a lot of repetition. So there was a lot of resistance to that, but it was kind of an eye-opener for me. But when you're looking at payment reform, that's a little bit of a different cat. And one of the things that we're trying to figure out is, I see in the bill you talk about preventable admission, that we've struggled with in the past, particularly in Medicaid population where you have repetitive admissions. Do you look at avoidable days? So in other words, people who are in the hospital that maybe don't really need to be in the hospital to get them to a more appropriate level of care or out of the hospital entirely if they're there too long?
Mr. Stroney.
Sure. And again, very, very good question in terms of avoidable admissions. And in the Minnesota Department of Health study, this was examined, in great detail. And so, the way the system works, as we all know, is that if you have good care in the community, primary care physician for the individual, a care management plan, if many of these Medicaid recipients will be high-cost, high-risk individuals because they have multiple chronic diseases, they have behavioral health issues. So it's a population that has to be managed by a primary care physician. So that's where the care, and if a managed care plan is responsible for that population, the incentive here is that if they manage that population very well and have effective care treatment plans, care management plans, they will keep that patient out of the hospital. Not all admissions are preventable. We're not saying that. Not all admissions readmissions are preventable. However, the incentives are built into these programs so that providers can look at the data and then ensure they have the correct programs in place to manage that population, whether it's a hospital or a managed care plan.
Chair Dean.
Thank you, Mr. Chair, and I really appreciate it. I like this bill a lot, the direction that it's going, but obviously when you measure value and you pay for value, how you measure that is everything. And who has skin in the game and who gets the incentives is really what we have to, I think, be very careful of when we are going down this path. But I do thank you.
You're welcome.
Representative Murphy.
Thanks, Mr. Chair. And so I just have a couple of questions as well. This is not a new concept for the legislature over time. And it is something that we've talked about and embedded. So as I'm trying to read through this again and through the information that you provided this morning, can you help me understand what we're adding that is new conceptually or in law that would change what's currently happening and what would be different?
Representative Albright.
Mr. Chair and Representative Murphy, I think that what we've found, and to the great credit of homegrown 3M, is a collaboration between the systems already in place. Data is everything, and I think as I've discussed this with the testifier as well as with the representatives from 3M, it's about mining the data and having fresh eyes on it. And I think that facilitates a kind of a reawakening to, as Chair Dean said, how do we prevent those never events, or to look at patient loads, whether they be high risk or not at high risk, to identify measurable outcomes that might be more beneficial in terms of less days, fewer overnights in beds, or reoccurring visits to either the primary care or the specialist, particularly when you have multiple situations or multiple occurrences, whether it be diabetes or hypertension, that type of thing. So what we're trying to do is bring a collaboration and a more comprehensive look. This is not to X anyone out from the conversation, and in quite the opposite. I think it actually encourages a greater collaboration from all the stakeholders.
Representative Murphy.
Thank you, Mr. Chair, and I appreciate that. And I think conceptually I appreciate what's being proposed, and I'm just trying to understand, or maybe one of you can walk me through like who does what to get to that goal, because there are a lot of players. We already have law in Minnesota. We already have law. I think the department already has some of this authority. Maybe we need to have the department come down and talk about that a little bit. But what is the role of a vendor? What is the role of the department? What is the role of the managed care organization, the hospital? Who sees the data? How does it get mined? I just need to understand sort of the linear, how does this work?
Sure. And I would just add, very good question. A typical program like this is the state Medicaid agency receives the data. They have all of the hospital discharge data. You've got an all payer claims database here in Minnesota. You also receive, the state's required to submit what they call encounter data. This is a bill that would normally be submitted if you run a fee-for-service system to the state that identifies the diagnosis and what treatment the person receives. So all of that data is received by the state. The data is then, in a program like this, would be through these software systems. You would run that data through the system, and the state already licenses these tools from 3M, the potentially preventable event tools, or other tools that the state might decide to use. It's not limited to 3M. Then reports are generated. You know, I'm oversimplifying it, but reports are generated on hospital ABC or hospital or managed care plan X, and those reports are submitted to those providers or the managed care plans, and it shows how well they are performing compared to their peers, and it will identify whether it's readmissions, ED visits, admissions. It will have actionable data that they can look at and analyze. They can actually drill down to the patient level, to the doctor, and examine the practices. Why are we different compared for the same procedures compared to other peer health plans or hospitals? So the key is giving much better data that a provider can act on. Today, and this is true of the U.S. healthcare system, we have what we call process measures. Typical HEDIS measures. It measures a certain conditions that a patient has. HEDIS measures are good, but what we're seeing across the country, and studies that have shown this, the movement is a way to measuring outcomes. Let the doctor do what the doctor does best and measure that outcome against peers and statewide norms.
Mr. Chair.
Representative Murphy.
Thank you. That's helpful for me. And I'm just wondering, Mr. Chair, if we would have time for somebody from the Department of Human Services to join this conversation. I just want to understand what we're doing today and what this would add in terms of outcome evaluation.
Absolutely. If someone from the department would please make their way down. Well, we've got a couple of them today, Representative Murphy.
It's a big question. And they look so excited.
Welcome back to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair. My name is Julie Marquardt. I'm with DHS. I believe the question is what does this do, or what are we currently doing that this would impact or not impact? Is that
Mr. Chair.
correct?
Representative Murphy.
Thank you, Mr. Chair, and thank you, Ms. Marquardt. I am curious to know from the department's perspective, what is, you don't need to do an exhaustive review of the law, but what do we have in place already that is furthering this goal? And what is missing that we would want to consider as we're listening to Representative Albright's bill?
Ms. Marquardt.
Thank you, Mr. Chair. So we have several initiatives right now that are in place that I think we would need to address if we were to implement something a little bit different. So we have withholds on the managed care organizations that address these three areas of emergency department use, admissions, readmissions. Those are in law right now, and we hold the managed care organizations financially accountable for those. That's done on an annual basis. We also have the integrated health partnerships, which is 21 organizations, nearing around 400,000 enrollees are attributed to these organizations. They also, as part of their quality measures, are measuring those three areas, and those are a component of whether they're eligible to get the full amount of their shared savings or are eligible to get their shared savings. So they aren't using the exact PPE method that is described in this particular bill, but they are using measures that are similar to, And I think one of the things that we have looked at, we did used to have, we just sunset about 2 years ago, related to the RARE campaign that was mentioned, we used to also have a 10% rateable reduction in payments to hospitals in an effort to get them to improve their readmission rate. And when that was accomplished, we actually sunset that about 2 years ago. And that applied to fee-for-service only. But I think one of the things, no matter which product you use, one of the difficult things is for providers to understand what parts of it, what were the steps they need to take to prevent the action. A lot of these are proprietary software, and so you can't necessarily understand why my patient flagged here, but their patient didn't flag there, and what is it that caused it to flag within the software. And so in order for providers to take the steps or institutionalize those steps, they need to probably have a little bit more deep understanding of the software itself and how it's flagging. The other thing is when you're holding financially accountable, the IHPs do it through a total cost of care, where we look at all of the costs for all of the care. But if you're doing it not within that arrangement, then it's difficult because sometimes the preventable action really isn't the hospital itself. It's something that happened outside of the hospital. It's something that should have happened in the outpatient setting, at a clinic, at a mental health facility, and you can't really hold, it's difficult to hold a hospital financially accountable for something that they don't have control over. So it's outside of a total cost of care model, it becomes more challenging to figure out who is the financially responsible entity. And then if something goes wrong, sometimes patients don't want wherever happened wrong to correct it. So now the costs that we're actually bearing are with another provider. But we can't necessarily hold them accountable because they didn't make the error in the first place. So it is a complicated system that I think the IHPs probably do the best job of looking at the total cost of care, and regardless of where that happens, they're accountable for it, they understand, they have a contract with us. But again, I don't think just simply changing the software is going to change the outcome. They actually are using and working with 3M on how to better give data and information to the IHPs, and whether or not that turns into some use with financial accountability, I think that's to be seen. But we're certainly open to looking at better ways to measure quality, to look for opportunities for providers or our managed care organizations to have more actionable steps that they can take to prevent things. But I do think there's some duplication here that this bill introduces, and I'm not sure that it's a value-added duplication at this point.
Representative Murphy.
Thanks, Mr. Chair, and I appreciate that feedback from the Department of Human Services, and we could probably spend a lot of time, maybe all of the rest of our 8:15 meetings, our 8:15 a.m. meetings could be just spent on this, and we could write a dissertation or something. One of the things that I think is most difficult about this, Representative Albright, is the idea that we would do this analysis in the department. I think it would happen in the department. And then it's got to be translated through various vendors and contracts, from the department to the health plans, and then from the health plans out to the networks of providers. And what we want to do, I think, is change the behavior of the providers themselves, whether it's the hospitals or the doctors or the nurses, et cetera. I think that's one of the tricks we've got to figure out. And, I'm interested in this. I'm interested in figuring out how to make this work, or how to achieve the goal that I think is embedded in your piece of legislation. But I worry about the translation of the data that we might generate at using a vendor and new software, and what that would actually mean for care provision.
Are there any other questions for the testifier? Is there anyone else who wishes to testify on House File 2115? If you could please make your way down. Welcome to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair. I'm Mark Sonneborn. I'm Vice President of Health Information and Analytics for the Minnesota Hospital Association. And I am speaking on behalf of our 142 hospitals and health systems we represent. We are opposed to this bill. As has been alluded to, there is already a quality reporting and incentive system in place in Minnesota for hospitals known as the Statewide Quality Reporting and Measurement System, or SQUIRMS. SQUIRMS has evolved over the years to align with federal reporting requirements to the Centers for Medicaid and Medicare Services, CMS. The CMS and SQUIRMS measures already include measures for readmissions and for complications. The measures described in this bill do not align with what is currently reported through either the federal government or SQUIRMS, so this would be a significant burden and confusion to hospitals as well as patients. The burden would be more on the analytics and quality improvement side than the collection side, so that the data burden is not as much. We have other concerns as well. This is based on Medicaid only. Many hospitals don't have sufficient Medicaid volume in order for the state to do a statistically reliable analysis of their performance. In fact, our own data show that 74% of Minnesota hospitals, that's over 100 of them, have less than 10 preventable readmissions for Medicaid in a year. There are simply not enough cases for most hospitals to make this a fair measure for an incentive program. We're also concerned, as been previously mentioned, that the language in this bill is vendor-driven. Likely outcome of its passage would be that hospitals have to purchase proprietary software to analyze their data. And I'd be happy to answer any questions.
Are there any questions for Mr. Sonneborn? Seeing none, the committee thanks you for your testimony this morning. Is there anyone else who wishes to testify on House File 2115? Seeing none, final questions for the bill author. Final word, Representative Albright.
Mr. Chair, and I think I will leave you with this. When you consider the fact that MA spend in this state is growing at a rate of about $2 billion per biennium, the testimony suggests that there are disparities in terms of the hospitals that do or do not have MA patient load. But when you consider the fact that our state budget and what we expend on behalf of our MA population, I think it's incumbent upon us to look and review very seriously every tool that comes our way to consider how we manage that caseload as effectively as possible. And in an era where big data is everything, and it is growing by volumes on a daily basis, I think it also becomes imperative for us to look at every tool, whether it is from a vendor, from internal to one of our agencies, to consider how we might be able to manage that caseload in a more effective manner. With that, I urge your consideration as we move this bill forward. Thank you.
With that, Representative Albright renews his motion that House File 2115 be referred to the Committee on Health and Human Service Finance. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 2115 is referred to the Committee on Health and Human Service Finance. Thank you, Representative Albright.